Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical free 2-week sessions again. So tonight we are going to do cardiology, and hopefully we should be able to finish cardiology theory session today. Okay, so we have done the initial cardiology cluster, which was the syncope cluster, and I hope you understood how the medicine cages works for the exam. We discussed like how the approach should be, how to start a case, how to explain things, right? So today we are just going to finish the cardiology with two more cluster. One of them is palpitation cluster and another is chest pain cluster. So do you have any questions from our first class, which was the cardiology theory class 1? Great. So we can move on then. So we will go with the palpitation cluster. Okay. So palpitation or nervousness cluster, they are usually the same thing. So sometimes patient can present with palpitation. The same differential diagnosis we also use in nervousness cluster. So let's start with what are the differential diagnoses for a patient who presents with palpitation. So we have got serious causes like ischemic heart disease, myocardial infarction. Then hypertension can cause palpitation in some patient, but most important is arrhythmia. Or sometimes some valvular heart disease, not very common. Arrhythmia is the main cause of palpitation. And arrhythmia will include SVT, atrial fibrillation, atrial flutter, so all of them. Could be CNS causes such as stroke, TIA, epilepsy, infection, trauma. So CNS causes can also come to us with palpitation. Not very important to rule out, but definitely it's something that we want to just to make sure that they don't have a stroke, epilepsy, infection, or trauma. More important is endocrine, like hyperthyroidism, hypoglycemia, and pheochromocytoma. So this is more common cause of palpitation. Anemia can be a cause, anxiety, panic attack, stress disorder. So psychological questions are important. If it is a female patient after 45, then palpitation nervousness can be a presentation of perimenopause or menopause as well. So you want to rule that out. Sometimes even you can't find out any organic cause except patient is drinking a lot of tea or coffee, and that can also cause palpitation in some patient. Recreational drugs, alcohol patients, smokers, they can have palpitation. Some medication can increase the heart rate, like an asthma patient who is taking a lot of salbutamol puffer or Ventolin puffer, that can also cause tachycardia or palpitation. Okay, so these are your differential diagnosis of palpitation or nervousness. So think about CNS CVS, endocrine, anemia, anxiety, menopause medication, and excess tea, coffee, or recreational drugs. So the important gauges that comes in exam under this cluster is this arrhythmia mainly. I've seen hyperthyroid coming in exam, hypoglycemia comes in exam, anxiety disorder, perimenopause sometimes comes as nervousness. So these are all important questions. Even there was a questions where patient was drinking 6 to 8 cups of coffee every day. And that can also be the cause of palpitation. All right. So look for any of them in the exam. So palpitation is an acute presentation. So patient will come to you that I feel like my heart is jumping, my heart is racing. So racing of the heart, or I can feel my heart beating. So any of this is palpitation. So first you go in, you introduce yourself, reassure the patient. and then make sure patient is vitally stable. So the initial thing will be the same like how we have discussed in the first class. Once you have made sure that patient is vitally stable, the next thing is history of presenting complaint, which is palpitation. So ask the patient that, can you tell me a little bit more about this palpitation? So patient will give you some idea, but you want to know that when did it start this time? How did it how did it start? Suddenly or gradually? What exactly were you doing when it started? Because sometimes it can be that patient is lying down and then the palpitation started, or maybe patient doing some exertional activities, then patient started to get the palpitation. So we want to know that what's causing this. It's also important to know whether it is for the first time or patient had previous episodes. So is it for the first time? If patients say no, I had it before, then you need to ask detail. So ask how many episodes so far? When was the first time you had it? Is there anything that brings it on? How long each episode lasts? How does it stop? Spontaneously, or do you need to do anything? Have you seen any doctor for this so far? So see that you need to get an idea about the episode. So can you tell me about those previous episodes? How many episodes so far? When was the first time you got it? Can you describe what were you doing when this started? How long each episode lasts? Is there anything that brings it on? Is there anything that makes it better? Or how does it stop? Spontaneously, or do you need to do anything to make it stop? Have you ever seen any doctor for it? So lots of questions we can ask if there is a previous episode, and we should ask it. A lot of time for palpitation, candidates ask them, can you tell me how does it feel like? Is it like they just tap on the table like this, or they tap on the table like they want to show regular or irregular? Nowadays, we don't like to do that. So you don't need to ask the patient that, tell me how the tapping looks like, or can you tell me that I'm going to tap on the table and tell me how your racing of the heart feels like. We don't need to do that. Okay, it makes some of the role player getting more annoyed if you ask them to do anything like that. Okay, so no need. We will understand it just by looking at the ECG anyway. We should also ask, is there anything that makes it better? Anything makes it worse? And we already asked how long each episode lasts. So that will be history of presenting complaint. After that, associated symptoms. So during these episodes, do you feel dizzy or lightheaded? It's very common in palpitation. Excuse me. So it's very common that during palpitation, some patients can get dizziness or lightheadedness, especially if it is a arrhythmia. So ask that, any chest pain, shortness of breath, any nausea, vomiting, excess sweating, any headache, any problem with vision or speech, any weakness or any loss of consciousness. So what you have done is that you, with the associated symptoms, you have actually done CVS and CNS differentials. So CVS will covered by chest pain, shortness of breath, nausea, vomiting, excess sweating. So that's basically you are ruling out MI or ischemic heart disease. For CNS, headache, vision or speech problem, and any weakness or loss of consciousness. Okay. So after that, we have endocrine causes. So for hyperthyroidism, have you noticed any change in your weather preference? This is a good question, but some candidates, some role player might not ask, might not actually understand that what is weather preference change. So if they say, I didn't get you, or pardon me, or what do you mean? So then you can explain a little bit that do you feel hot in even a cool weather? Or like, do you always feel very hot and sweaty these days? So if a patient feels very hot and sweaty, even in the winter time or even in the cold times, that can suggest that yes, they have a that preference of being in cold because they are always hot and sweaty, which is a feature of hyperthyroidism. So ask this question, have you noticed any recent change in your weather preference? Any change in your bowel habit? Any change in your body weight? So hyperthyroidism patient, they can have diarrhea and they can have loss of weight. So even though their appetite is good, still these patients can lose weight. So that's for hyperthyroidism. For pheochromocytoma, do you get any episodic headache, sweating, or flushing of the face? So pheochromocytoma, it's an adrenal gland tumor, and these patients, this not very common. It's not an exam case. It's very unlikely it will ever come in exam, but we will rule that out. So episodic headache, flushing of the face, and sweating. Along with that, this patient gets hypertension as well. For ruling out hypoglycemia, you can ask that, did you skip your meal today by any chance? Do you have any history of diabetes? So if a patient did not have the breakfast or lunch and then went to a very hot, sunny weather and went out for running or jogging, that's a severe exertional work and the patient did not eat anything. So their blood sugar can drop even if they don't have a history of diabetes. Okay. So ask this question, did you skip your meal today by any chance? And do you have any history of diabetes or high blood sugar? For anemia, do you feel very tired and fatigued these days? That's only one question will be enough. For infection, sometimes if a patient has ongoing infection, like a flu-like symptom, that can also cause palpitation. So do you have any fever, cough, any shortness of breath, any runny nose at the moment? Electrolyte imbalance can cause this, so any vomiting, diarrhea. And then ask about, do you smoke or drink alcohol, any recreational drugs? Are you on any regular medication? Any past medical history like high blood pressure, diabetes, or any other heart condition? Do you drink excessive tea, coffee by any chance? Any family history of sudden death due to any heart condition? Give some confidentiality. Say that I'm going to ask you about your home and work situation. Please be aware that this is confidential between you and me. How is home? Is there any stress there? Any stress at your work? Are you an anxious person? Okay, so patient who has generalized anxiety disorder, they are always anxious. They worry about everything. So that can also present as palpitation. So find out if there is any stress at home or work. Find out, are you generally an anxious person? Do you worry a lot about most of the trivial things? So even with the small things, they worry a lot. If it is a female patient, ask about the last menstrual period. If it is above 45-year-old female, ask about when was like, do you have any menopausal symptoms such as any hot flush? Do you get mood swings, night sweats? Okay. So, because this is one of the questions in the exam as well. Excuse me. So that will be your history for palpitation. So to recapitulate, first introduce, reassure the patient that you are going to take care of them, and then hemodynamic stability, ask about palpitation in detail. Then we go for associated questions, CVS and CNS. DD will be included as endocrine cause, hyperthyroidism, pheochromocytoma, hypoglycemia. Then rule out anemia, infection, electrolyte imbalance. And lastly, SADMA, tea, coffee, past medical and family history, and social history as well. social history is very important to rule out because just because, let's say, you found that patient has got like some organic cause, don't forget to rule out some associated psychological cause as well. So sometimes in exam, they can give multiple finding. Patient has SVT, and you found that the SVT is caused by excess coffee or excess or not, or there is no organic cause. Sometimes it can happen in even a healthy patient. Along with that, you have also found patient is under a lot of stress. So your diagnosis should include both SVT as well as anxiety. So that's why it's important not to just focus on a single diagnosis in all cases. Sometimes multiple diagnoses can be there. Clear, everyone? Because we are going to use this history format for all the palpitation cases. And the question, Dr. Saida, you asked, so if I want to admit the patient to the hospital for workup, do I need to tell the patient all management or just enough to say cardiologist will assess you and after investigation? No. So if management is a task, you have to give a proper idea about what management can be there. All we do is we give some options that these are the options that possible option cardiologist will choose. Okay, so you can't give the specific management, but if management is a task, you can't just say that I'll do the investigation and cardiologist will do further management. You're supposed to at least mention what are the possible management in this case, and cardiologist will choose it based on the investigation. Okay, moving on to the physical examination from examiner. Remember the last class when we have done this? Exactly the same. Nothing is different. So we use the same physical examination format for any cardiac cases. So we don't need to basically even discuss this. We can move to the cases. So the first case is supraventricular tachycardia. You are a junior HMO in an emergency department. A man came in with thumping or racing heart with giddiness started today. Take history from patient, physical examination from examiner, ask investigation from examiner. Sometimes this kind of case, they will also say that explain the investigation to the examiner. What is the most important investigation in a patient who comes to us with racing of the heart? Yeah, ECG, right? Very good. So you will need to ask for a ECG from the examiner, and examiner will give you a copy of a ECG, and you need to explain that ECG to the examiner. So that's usually commonly asked in the exam. And then they can say, explain the diagnosis and differential to the patient. So in this case, patient, the positive points will be, so the history and physical examination we don't discuss because it comes under this cluster. So your history will be the same. And when you ask those history, you will find out that patient having palpitation and lightheadedness for the last 2 hours. Associated shortness of breath. Previously, 3 episodes started suddenly, lasted 2 hours, and then stopped suddenly as well. Takes 6 to 8 cups of coffee a day. No smoking alcohol, no other problem. Patient is also having some stress and anxious personality too. So you can see that there are multiple factors here, and all of these are important. So once your history is done, and you have also done the physical examination from examiner, so physical examination will be normal, right? Because this is arrhythmia case. Except for tachycardia in the vitals, everything should be normal. So when they provide you an ECG like this, you need to know how to read an ECG very quickly. So let's first have a basic idea. And I'm sure you have done this in your MCQ preparation. You must have done the ECG. So we'll give you a quick idea. So in a ECG, you have got some limb leads and you have got some chest leads. V1 to V6, all of these are chest leads, and lead 1, 2, 3, AVR, AVL, AVF, these are limb leads. So this is why, so 6 chest lead, 6 limb leads, which is the 12 lead ECG. Now, if you see in an ECG, there is always this kind of like a long lead, and the long lead is given usually at the end. And the long lead is something that you can see for the whole ECG paper. But these ones are quite small, like lead 2, you can only see up to this, right? In here. But the long lead in here, which is also the lead 2, that's where you can actually see any kind of arrhythmia problem. So if a patient comes to us with palpitation, the main lead we are going to look at in exam is the lead 2 or any long lead. If a patient comes to us as a chest pain, then we should look at V1 to V6 for any ST elevation. So depending on the presentation, in exam, you should mainly focus on that specific part. Okay? So we know from this history that this is a palpitation problem. So we know in our head that, well, we know it could be SVT, AF, like atrial flutter fibrillation, so something like that. So look at the long lead. In the long lead, the first thing we look at is the rate and rhythm. So heart rate is measured like this. So 300 divided by number of large square in between two RR interval. So this is one R, this is another R. This is another R, right? So if we look over here, that every RR interval is equally placed. So that is called regular rhythm because every RR interval is equal. So rhythm is regular in here. And when we check the heart rate, we look at how many large square is there in between two RR interval. We can see from here, it's one large square and a little bit like maybe half of another square, right? So if it is only one large square, you divide like this. So 300 divided by 1. If it is two large square, then 300 divided by 2. If it is three large square, then like that. So your heart rate is usually like 300, maybe 150, 100. So what I want you to memorize is you should be able to give a approximate heart rate. You don't need to do this calculation. So whenever you will see, yes, there is only one large square between two RR, it's most likely 300 heart rate. If I see two large square, then I know that it will be 150. If I see three large square, it is 100. So you should think in that way rather than doing the math in your head. Okay? So in this case, this heart rate, it is, if you see here, it is one large square and just another smaller square. So even if you don't calculate it, it's fine. So you know that it is definitely 300. Maybe we can say 280, 250 like that. Okay. So you don't need to be completely sure. You can just give an approximate heart rate in the exam. Okay. So now we know how to measure the heart rate. And heart rate is usually needed for this kind of regular rhythm cases. For atrial fibrillation, where rhythm is irregular, they don't even ask you to talk about the heart rate because it is difficult to measure. So heart rate and rhythm will come first. Then, so we can understand from here that this patient's heart rate is elevated. We can understand it is a regular rhythm. Then we look at the P wave. So So that's the normal waves in others. So this is P wave followed by QRS, and that's T wave, and then there is P wave like that. If you look over here, so this is QRS complex. After QRS complex, you get the T wave. So this is T wave. So you are actually missing P wave in this patient. So there is no P wave. So absence of P wave. The second thing is QRS complex. A normal QRS is ideally between 2 to 3 small square. If you look over here, it is barely 1 small square, this QRS complex, right? That is also known as narrow QRS. So we have got lack of P wave, narrow QRS complex, and after QRS, we have got the T wave. So look at the T wave. T wave is normal, and we also look at the ST wave. So this is ST. So if you see here, this is QRS. So this S and then the T. So this bit over there, that's called ST. So that's your ST in here. And ST is normal as well. So when we read an ECG, especially for arrhythmia, we need to make sure that we know what is the rate on rhythm. We know that the P wave present or absent. We need to talk about QRS complex, ST wave, T wave, and the QT interval. So looking at this ECG, you can understand that this patient has got something like this. So narrow QRS, absence of P wave. And that's how SVT ECG looks like. So SVT ECG, the classic pattern is heart rate elevated, rhythm regular, okay? Then no P wave, QRS will be narrow, and others will be normal. Does it make sense, guys, the ECG? Once you can come to a diagnosis that, yes, I know this is a SVT ECG, you can very quickly look at the V1 and others looking for any ST elevation. When we do the chest pain cluster, I will show you how the ST elevation looks like. But for palpitation cases, you should look at the long lead and find out whether it is a SVT case, atrial fibrillation, or flutter, because this is the 3 most likely cases that comes in exam. Okay, so if you understand it, how to explain ECG to an examiner. So you'll say, dear examiner, I would like to describe the 12-lead ECG of my patient, Mr. John, a 25-year-old gentleman, came with sudden onset palpitation and giddiness. His ECG shows heart rate. Now, for this patient, heart rate was almost 280, you can say. Heart rate 280 beat per minute, regular rhythm, absence of P wave, narrow QRS complex, no ST wave changes, T wave normal, QT normal as well. And that's it. So you don't need to even say patient most likely has got a supraventricular tachycardia. But if you want to say to examiner, that's fine. So you can say that my most likely diagnosis is supraventricular tachycardia. Thank you, examiner. So there is a format of explaining ECG to an examiner. It should be like this. So first you talk about rate and rhythm. Then you say, how is the P wave? Is it absent or present? Then how is the QRS complex? And then we talk about ST wave, T wave, and then the QT interval. All right. Any questions, guys, for the ECG? So how we are going to explain this ECG to the patient, or how we are going to explain supraventricular tachycardia? As I said in our last class, You don't need to explain the pathophysiology to a patient. All a patient wants to know is whether they understand why I'm feeling giddy or palpitation. If you can explain it to them, they will be happy. So explain to the patient that, thank you so much for all the information. So as you could see that we have done a ECG on your heart, and that was done when the nurse put those cords on your chest. The lines that you can see in the ECG, that's the electrical impulse that conducts in our heart. Let me draw a picture for your better understanding. So this is our heart. The electric impulse originates from here, and then it goes over all the heart, and it helps to pump the blood to our whole body. In your case, there is some abnormality in this electrical impulse, which is causing your heart to beat faster than normal. Most likely, the abnormal electrical impulse is coming from the upper chamber of your heart, and that's one of the conditions we call as supraventricular tachycardia. Because your heart is beating faster than normal, you are having this racing of the heart, and your heart is not getting enough time to fill in. So your brain is not getting enough blood, which is why you're feeling the giddiness. Are you with me so far? Are you understanding me? So see that that's how we need to explain. We don't need to talk about re-entry arrhythmia or pathophysiology of SVTF. They don't care. All they want to know that why I'm feeling giddy and palpitation. And as long as you can explain it clearly in the exam, you will be fine. And then after that, you can say that this condition can happen due to lots of causes. Sometimes SVT happens in a healthy young patient without any cause. Sometimes it can be due to that if they have any structural heart disease, any valvular abnormalities. Some medication can cause this, thyroid, infection, salt imbalance, anything can cause this. In your case, so in here, there is only diagnosis and differential. So you can say in your case, I think that because you're drinking 6 to 8 cups of coffee, that might be one of the cause of your palpitation. On the top of that, you are anxious and you have a lot of stress going on. That's also contributing to this palpitation. Apart from this, palpitation can be due to other causes, like some hormonal causes, like if you have any thyroid imbalance. In that case, you would have like you'd feel very hot and sweaty, but you don't have those symptoms. It could be a condition called hypoglycemia, where blood sugar falls low, but in your case, that has been okay. It could be electrolyte abnormality, but you did not have any excessive vomiting, diarrhea. So you can always give some differential that you have ruled out and say why it is unlikely. Now, management for this kind of condition doesn't come in exam a lot, especially for face-to-face exam. But it's not a bad idea just to remember just a bit of explanation about the management. So any of these, especially if it is a SVT, the first thing we look at is that this patient needs to be treated in an emergency department. So if it is in a GP clinic, you will need to send the patient to the hospital. If it is in the hospital, you will admit the patient, call your senior, and a cardiologist will come and talk to this patient. In between that, what we do that we check whether the patient is vitally stable or not. If a patient is vitally stable, the first line treatment for SVT is vagus or vagal nerve stimulation. This vagal nerve stimulation can be done by several processes, Valsalva maneuver. It can be done by immersion of the face in a cold water. It can be done by carotid sinus massage. We no longer do carotid sinus massage because of risk of dislodging a clot and causing a stroke. So the common vagal nerve stimulation is the Valsalva maneuver. In Valsalva maneuver, you ask the patient to take a deep, like to close their nose and then take a deep breath through their mouth and then close their mouth and try to breathe out through their ears as if they are popping out the ear. That's called Valsalva maneuver. So close the nose, take a deep breath from the mouth, and then breathe out through the ear, not through the nose or mouth. Okay. So that will stimulate the vagal nerve. If vagal nerve stimulation does not work, then the next option will be adenosine. So adenosine IV is the next option. So cardiologist will start that and it can be repeated if needed. If adenosine is not working or not available, then the option will be beta blocker like metoprolol. Even after that, it's not getting any better. The last option would be DC cardioversion, which means giving a shock to this patient. Okay. If patient is unstable, which is not an exam case, that's a patient who will need a urgent DC cardioversion. So this is the treatment, but treatment doesn't come in exam because this is not what you are going to treat. You are going as a junior doctor. If you can diagnose SVT, if you can, if you know what causes it, if you know what to do for this patient, that's all that they would like to know. Okay, but that's usually just the management, like the basic management that you should know. Clear, everyone? SVT, any questions? We can use verapamil also. Yes, we can do Valsalva maneuver in a GP setting. If a patient is stable, Valsalva can be done in a GP setting, yes. Okay, moving on to AF or atrial fibrillation. A middle-aged lady comes to the ED with sudden onset palpitation, history, physical examination from examiner, investigation from examiner, and explain the causes and complication of the condition. So this is a bit different task. So in here, you need to get the diagnosis, explain the cause, and also the complication. So in this case, the same history you'd get like palpitation, giddiness, the same thing. Once you come to the ECG, again, this is a palpitation case. So you look at the long lead. In the long lead, you can see that the RR interval, they are not regular. So that will immediately hit you that, well, I know that it is likely to be an atrial fibrillation. It could be flutter, which will be atrial flutter with variable block, but mostly atrial fibrillation. In a patient who has irregular rhythm, you don't need to calculate the heart rate. So next thing is, where is the P wave? In atrial fibrillation, we know that we can't see the P wave because P wave will be replaced by fibrillatory wave. And that's what we can see here. So there is no specific P wave. These are all fibrillatory or wave-like P wave. So when we have got P wave replaced by fibrillatory wave, which is like this, Then QRS complex can be narrow and others are normal. So when we discuss the ECG of a AF, we will say that heart rate is increased, irregular rhythm, absence of P wave and replaced by fibrillatory wave, narrow QRS, and others are normal. So no ST wave problem, T wave normal, QT interval normal as well. So understanding this actual fibrillation, actual flutter ECG is really important for the exam because many of you will get this kind of case in your real exam. Okay. Any questions regarding the ECG of atrial fibrillation? So if I draw the atrial fibrillation ECG, you will see that it's something like this. So you get the T wave, but the P wave will become fibrillatory and the rhythm will be irregular. That is the time we call it atrial fibrillation. Okay, Dr. Mahin. So that's the fibrillatory wave. So ideally what should happen that if this is T wave, then you get a P wave and then the QRS complex, right? So this is P, then QRS, and then T. But what will happen? So that's T wave, and then this is the fibrillatory wave, QRS, then the T, and then again the fibrillatory wave. So when you get this fibrillation, that's the classic fibrillatory wave that we look for in an AF patient. Whereas in atrial flutter patient, this looks kind of a sawtooth appearance, like this. So when the P wave looks like sawtooth pattern, then we can say it is atrial flutter. Clear, everyone? And in a patient who has atrial flutter, you will see that their rhythm is regular. So most of the patients, so it's not always that flutter patient will have irregular rhythm. Flutter patient can have irregular rhythm as well. But most of the time, you will see that flutter will have regular rhythm. When flutter patient can have irregular rhythm. So let's say now what you are seeing in here, this is called 2x1 block. So 2P wave followed by, oh, sorry, 2P wave followed by 1 QRS. So 2x1 block. In here, we have got 1, 2, 3, 4, 5. 5x1. So 5P wave followed by a QRS complex. So when it is variable block like this, then even though we have the sawtooth pattern, you will see that there is an irregular rhythm because of the variable block. If it is same constant block, then it will be regular rhythm. Make sense? Okay. Now, good thing about atrial fibrillation is that the explanation is exactly the same as SVT. because it's the same thing. So the only difference is when I say, so you'll explain to the patient that this is the electrical impulse of your heart. The electrical impulse originates from here, goes all over. So same thing. In your case, there is some abnormality in the electrical impulse, causing your heart to beat faster than normal and also in a chaotic way. So sometimes your heart is beating faster, sometimes it is not. So it's not following any regular pattern. And that is why you are having a racing of the heart. And because most of the time it is beating faster, your heart is not getting enough time to fill in. So your brain is not getting enough blood, which is causing the giddiness. So the only thing you would add in this explanation is that in here, your heart is beating faster than normal and also in a chaotic pattern. So that chaotic pattern is the explanation for AF. After that, you can say that there are lots of causes of atrial fibrillation. Many times it can be idiopathic, that means no known cause, but sometimes it can be due to high blood pressure, which most likely in your case, so if you get a high blood pressure in this patient, you will say, so this is most likely the cause in your case. Could be any underlying heart condition, such as coronary artery disease, where the heart artery or blood supply get blocked by some fatty depositions. Could be some abnormality in the heart valves, which regulate the blood flow in between each chamber of the heart. Could be some heart defect patients born with, any overactive thyroid gland, sometimes even exposure to stimulant such as medication, caffeine, tobacco, or alcohol. So you can give all these causes of AF one by one, because that's one of your tasks. If differential diagnosis is a task, then you can also talk about some differential in this patient. And then you'll say that, like, left untreated, this can cause complication, such as because the chaotic rhythm may cause the blood to pool in your heart upper chamber and can form a clot. And if a blood clot form, it can dislodge from the heart and it can travel to your brain. And if it blocks the blood flow to the brain, it can cause a stroke. In atrial fibrillation, especially when it is not well controlled, it can weaken your heart and it can cause a heart failure, a condition in which your heart cannot circulate enough blood to meet your body's needs. So these are possible complications that can happen in this patient. But please don't get scared, because now that you are here, we know what you have got. And with appropriate treatment, this complication should not happen. See that this is called reassurance, which is really important for AMC clinical exam. Although management is not a task and not always a task, still I would like you to know about the management. So just a basic knowledge will be fine. So patient needs to be admitted in the hospital, seen by your senior, seen by a cardiologist. You will order some necessary investigation, which will include blood count, inflammatory marker, liver, kidney functions, blood sugar level, lipid profile, and thyroid function. Okay, so this is usually the basic one. So full blood count, inflammatory marker, liver and kidney function, blood sugar level, lipid profile, thyroid function. And then, as part of further management, the cardiologist might want to reduce the heart rate by giving some medication. So if patient is vitally stable, first treatment will be reduce the heart rate. And that can be done by some beta blocker or calcium channel blocker. So you can give them any of them, like metoprolol or atenolol, bisoprolol, any of them. Or we have got verapamil, so rate limiting calcium channel blocker, or diltiazem, right? If rate control doesn't work, then we go to the next step, which is rhythm control. And the common rhythm controller would be, so we can use flecainide, sotalol, and if that doesn't work, we have amiodarone. If still that's not working, the next option is a DC cardioversion. All of these are decided by a cardiologist, but you will just mention all of the possible management. Along with that, every AF patient needs needs a evaluation whether they are high risk to develop a stroke from AF. So we need to talk about the possible start of an anticoagulation medication in this patient. So we use the CHATS VASC score. If the CHATS VASC score shows that patient has, especially if it is a male patient, and the score is more than 3, then we would start the patient with a blood thinner. And the blood thinner nowadays that use is the newer oral anticoagulant, which will be apixaban, rivaroxaban, or dabigatran. We no longer use heparin, warfarin in this patient. Okay, so in exam they don't want you to do this test versus score, but most of this patient will be eligible to get the blood thinner. Now, if management is a task, definitely you should know how to measure a CHATS VASC score. So let me show you how that means, like what exactly it is. Okay, so in the CHATS VASC score, so you can see that these are the things we look for. Heart failure gets 1 point, hypertension 1 point, age more than 75, so A2 gets 2 point, diabetes 1, has a prior history of a stroke gets 2 point, any vascular disease like peripheral vascular disease 1 point, 65 to 74 age gets 1 point, and female gets 1 point. So that's the CHATS VASC score. According to the new criteria, if the male score more than 2 or female score more than 3, they would be eligible to get a blood thinner. It's no longer aspirin, warfarin like before. Now we don't give aspirin in this group of patient anymore. The only thing that you give that either this patient will need an anticoagulant or they will not need any. So if the score fulfills more than 2 for male, more than 3 for female, then you would be able to go for a newer oral anticoagulant for this group of patient. If the score is less, then no need of any anticoagulant for this. Okay? Is this clear for everyone how to treat the atrial fibrillation? And again, if it is an unstable atrial fibrillation patient, we'd go directly for DC cardioversion. So it's very unlikely that exam will ask you to discuss all the management. But again, as a junior doctor, still you should know the what are the management that is available for a AF patient. Brilliant. So that's the main two things we would like to discuss for palpitation cluster. Okay. Sometimes we want you to keep your mind open in exam because anything can come. So look for whether it is a perimenopausal case, whether the palpitation, maybe patient had a diarrhea, and that's why because of electrolyte abnormality, patient getting palpitation. So anything can appear in the exam. So make sure that you keep your mind open. Don't think that it is always a case of AF or SVT in a palpitation cluster. Okay. Now, I would like to take a 5-minute break. And after that, we will start with a very important cluster, which is chest pain cluster. Out of anything that we will discuss in cardiology, chest pain is the super important because you will get questions from here every month. Okay. So let's take a 5-minute break and then we'll start with chest pain. Thank you. All right, everyone, let's restart. So we want to start with the chest pain cluster now. So chest pain is really important, as I was mentioning before the break. So as always, the differential diagnosis of chest pain is the first thing that you need to learn. So chest pain, the first thing is CVS. So the most important thing to rule out is myocardial infarction or angina, which is like ischemic heart disease. Acute pericarditis can come as chest pain. Aortic dissection, aortic stenosis, they can also present as chest pain. So these are the common causes of CVS-related chest pain. Respiratory, so pneumonia, pneumothorax, pulmonary embolism, very important cause. GIT causes like gastroesophageal reflux, peptic ulcer disease, esophagitis, gastritis, any of those can cause chest pain. Musculoskeletal, there is a condition called costochondritis, where patient will have tenderness on palpation on their costochondral junction. So this is one of the cause of chest pain where you will feel where patient will say, yes, it is tender to touch. Okay. Refracture, neurological cause like disc prolapse, like thoracic disc prolapse can give a radiating pain on the chest. Herpes zoster, important to rule out, and psychological like panic attack, anxiety related. This is also important to rule out. So lots of causes, lots of differential diagnoses that we need to rule out in a chest pain patient. So remember about CVS, respiratory, GIT, MSK, and neurological and psychological. Okay. So how we are going to take a history for a chest pain case. So if you think that a patient coming to you with a sudden onset chest pain and the patient is middle-aged or elderly, so ideally if the patient is more than 40, you think that, yes, I need to rule out myocardial infarction in this patient. So until you prove otherwise, that patient will be treated as most likely having a heart attack. So any sudden onset chest pain in a middle-aged or elderly patient will be treated as if that patient has got a heart attack until you can prove it otherwise. Okay, so how we are going to start this case? This case has several ways to start. So sometimes it depends on a lot of factors. So let's say we start in this way. So, hi John, this is Dr. Arshan. It's one of the doctor in this emergency. Very nice to meet you. John, I can see from the note that you are having a chest pain, right? Yes, doctor. Well, I'm so sorry to know that, but now that you are here, we are going to take care of you. But before I ask you any more questions, please excuse me for a moment. I will just talk to my examiner and come back to you. So you turn to the examiner and say, dear examiner, I would like to know if my patient vital is stable for further history. Examiner says, proceed. Thank the examiner, come back to the patient and say, thank you, John, for waiting. John, would you please tell me how severe is your pain in a scale of 1 to 10? So it's 9 by 10. You'll say, I'm so sorry to know that. Do you have any allergies to any medication? No? Well, I'm going to give you a strong painkiller and hopefully you will feel comfortable after that. So you don't need to mention the name of the medication. Just say that you're going to arrange a strong painkiller. If you like to say morphine, that is fine. Well, now there are several ways in these cases that how we can start this kind of question, this kind of case. There is a case where they already give you a chest pain patient with a ECG, and the ECG is a patient who has ST elevated MI. That case is a different start, unlike this case. This case we are not still sure because we haven't seen the ECG yet. So for something where we don't have the ECG on the stem and we don't know yet, we will start like this. So we will start with the vitals, we will offer painkiller, and then we will go with the history. So you will say, well, John, would you please tell me a little bit more about this chest pain that you have got? So any kind of pain, we use this Socrates, right? So Socrates is site of the pain, onset of the pain, character of the pain, radiation, associated symptom, time or duration of the pain, exacerbating and relieving factor, and severity. We already asked the severity, and we will just ask the rest of it now. So we want to know, when did it start? What were you doing when it started? Did it come suddenly? Is it for the first time? Is the chest pain continuous or on and off? Can you exactly point out where is the pain? So site of the pain. Does the pain go to anywhere? So you can't ask, does the pain radiate to anywhere? Just say, does the pain travel or go to anywhere? How does the pain feel like? Very important question. If it is a case of MI, the chest pain will be left-sided and the pain will be crushing, tightness, pressure, or heaviness. And the pain will be severe. The patient might also have like a radiation of the pain to the left arm, neck, and jaw. So that's a very classic symptom. Whether it is a case of pericarditis, that patient will say it's a sharp, stabbing chest pain. Pain can be left-sided or retroesternal, and the pain does not radiate to left arm or neck or jaw, but it gets worse with lying down or taking a deep breath, and it gets better when they lean forward. So that's why the characteristic of the pain, that is it a sharp stabbing pain, is it a heaviness, is it a like a tearing sensation? If a patient says excruciating, tearing, knife-like sensation, and it's retrosternal, radiating to the back in between the scapula, it can be a feature of aortic dissection. So the character of the pain is really important to even get some idea that what this case is. Then ask, anything makes it better, anything makes it worse. Okay? If you want to ask directly, like anything makes it worse, like breathing, coughing, doing exertion. Chest pain, which is coming from the heart, will get worse with exertion. If it is a pleuritic cause, like pericarditis, pneumonia, or pulmonary embolism, those pain usually get worse with breathing or coughing. Okay, so ask about all the Socrates question, but most important question is, when did it start? Where exactly is the pain? Does the pain go to anywhere? How does the pain feel like? Okay, so these pain questions, we are going to use the same questions in every pain case. Okay, and we'll just say that, well, the same pain question. So we will not discuss this again. So after the pain questions, associated. So along with the pain, have you got any shortness of breath, any racing of the heart, any nausea, vomiting, excessive sweating? So what you just ruled out, MI, because these are all MI questions. After that, some other DDs. So for acute pericarditis, you can ask, did you have any recent flu-like illness? It's very common that pericarditis patient will have a viral illness, and then the patient has this kind of stabbing pain. Does the pain get worse when lying down? Does it get better when you lean forward? For aortic stenosis, any dizziness or any sudden blackout. So you remember the aortic stenosis case that they get chest pain, shortness of breath, and syncope. After that, we go to the respiratory causes. So for pneumonia, any fever, cough, shortness of breath. For pneumothorax, is there any chance that you might have any trauma to your chest? Any history of any lung condition? For pulmonary embolism, any recent travel to anywhere, any past history or family history of clot in your legs or lungs. So these are your respiratory causes. Then you move on to the GIT causes. For reflux, does the pain has any relationship with food, any heartburn, or any bitter taste in your mouth? So that's the same reflux question. For musculoskeletal, we have costochondritis. So is the chest sore to touch? For herpes zoster, any rash on your chest? For anxiety or panic attack, so say that I'm going to ask you some personal questions, but it will be confidential. So is there any stress at your home or work? Are you generally an anxious person? Okay. And then finish with SADMA. So do you smoke or drink alcohol, any recreational drugs? Past medical history, so diabetes, blood pressure, cholesterol, any family history of heart condition, and also if the patient is on any regular medication. Okay. So a lot of questions to ask, right? So you'll ask so you start with the vitals, painkiller, ask all the chest pain questions, then go to the DD one by one. So we have to rule out MI, then pericarditis, aortic stenosis, then the respiratory cause, GIT cause, musculoskeletal, neurological, and then anxiety. Okay. And finish with SADMA, past medical history, and family history. Your physical examination will be exactly the same. But if it is a pericarditis case, sometimes that patient can have a pericardial rub. So on auscultation, apart from S1, S2, is there any added sound like murmur? You can just add this, that any pericardial rub. So that is a finding that we get in pericarditis patient. So that's your chest pain history and physical examination. Now we are moving on to the cases. The first case is this one, pericarditis. 50-year-old tram driver present with a sudden onset chest pain for the last 2 hours. Now, if you look at this question, you would not think it as pericarditis, right? You would rule out myocardial infarction in this patient. So, but sometimes even this case can be a pericarditis case. So don't just assume everything is MI also. So this patient has got chest pain for the last 2 hours, and the pain gets worse with lying down and deep breathing, relieved by leaning forward, stabbing pain, flu-like illness a week ago. And they say that, yes, it radiates to the back. Now, again, pericarditis pain can radiate to the back. Just because it is radiating to the back, it is not aortic dissection. Okay? So you have got all the features of pericarditis. Then they give you a ECG. When you get a chest pain patient and you look at the ECG, we should always start with the chest lead. So in the chest lead, what we see, so this is P wave QRS, and that's the T wave. That's all good. V2. So normally this is called isoelectric line. So everything, all this segment will be in the same line. But if you look over there, so V2 is not that much evident, but V3, if you look, so this is the isoelectric line. And if you look over here, that's the QRS. Now that's the ST. So ST, ideally, it should be over here, right? Because it should be in the same isoelectric line. But now it is elevated. So when ST is elevated from the isoelectric line, that is the time you call it ST elevation. Is ST elevation making sense for everyone? That what is ST elevation? Because if you don't know what is ST elevation, you can't get the diagnosis right in exam. Okay, now that we know how the ST elevation looks like, so this ST elevation is a bit unusual than myocardial infarction ST elevation. you can see the pattern that V2 had a bit of ST elevation. V3 has a ST elevation. V4, you can see that it's kind of a concavity upward, right? Same, same. So almost all of them has got a ST elevation. Let's come to lead 1 and lead AVL. These are called high lateral leads. So if a patient has got ST elevation in the anterior leads, so V1 to V6 are anterior leads. The next thing that we look at is how is the high lateral leads, which is your lead 1 and AVL. So lead 1 has got ST elevation. Lead AVL has got mild ST elevation. Now we have got inferior leads left. So lead 2, 3, and AVF, these are inferior leads. So lead 2, we can see that there is a bit of ST elevation. Lead 3, nothing. Lead AVF, not much. But lead 2 definitely has a ST elevation. Now, this is called widespread ST elevation in almost all leads. In a patient who has ST elevation in anterior leads, ideally, the inferior leads should not also have a ST elevation. It's very uncommon. So let's say someone has got a ST elevation in lead V4, V5, V6. So it means in the anterior lead. In the inferior lead, the ST wave should be normal or they can be depressed. So ST depression can happen or ST can be normal, but it should not be elevated. So that is called like myocardial infarction. In MI ST elevation, we get this reciprocal change between anterior and inferior leads. Exactly the same way, if it is an inferior MI, that means you get ST elevation in lead 2, 3 AVF. In the anterior lead, you should not get ST elevation. You should get either a normal ST wave or a depressed ST wave. So that is what we call as reciprocal change. But in a patient with pericarditis, this rule will not be followed. They will get ST elevation in anterior lead, high lateral lead, and also inferior leads. So when all the kinds of leads are having ST elevation, and the ST elevation is this kind of concavity upwards, that is what we call as pericarditis ECG. Did it make sense, guys, that what's reciprocal change and everything? Because in exam, it might get tricky because whenever you will see ST elevation, you will think that it is a ST elevated MI, but it's not always because you will get ST elevation in a pericarditis patient also. The only clue in the exam would be that if you have got ST elevation in all the anterior leads, you have got it in the high lateral leads, and also in the inferior leads. That is the time you would think that, well, they don't have any reciprocal change, so it must be pericarditis patient. So how we are going to explain pericarditis? So you'll say most likely from history, physical exam, and the ECG, you have a condition called acute pericarditis. So you can draw a picture. So you can say that this is your heart and the outer layer of the heart is known as pericardium. In your case, you have got an inflammation in the outer layer of the heart. Now, most likely this inflammation is related to the recent viral infection that you had. As the covering of the heart is inflamed, that's causing this stabbing pain, especially when you are lying down or when you're taking a deep breath. But it could be due to other reasons as well. So give all other DD and say why it is unlikely. But I can assure you that it is not a heart attack. Still, I would like to confirm my diagnosis and I would also like do some investigation to rule out other possible causes. I will also involve my senior and a heart specialist will come and review you. In the meantime, we will insert IV line and take some blood for necessary investigation, including a blood count, inflammatory marker, kidney, liver function. We might also do a repeat ECG to check for any changes, cardiac enzyme known as troponin to rule out heart attack, and also a echocardiogram of the heart might be ordered by the specialist who can confirm whether there is any sign of inflammation in the pericardium. If it is confirmed that yes, it is pericarditis indeed, then there is nothing you need to worry about. The management will be bed rest and some anti-inflammatories to reduce the pain. The specialist will discuss that in detail. In the meantime, I'll give you some reading materials to learn about pericarditis. If you have any questions, feel free to ask me, please. Okay, so that is pericarditis treatment. Do you know that how long some of the pericarditis management can last? So the treatment of choice for pericarditis is anti-inflammatories. So you can give like naproxen, ibuprofen. So commonly ibuprofen, high dose ibuprofen, and it is for 3 months. If patient cannot tolerate NSAIDs, then option is colchicine. That's also for 3 months. So any of these can be given as part of a management. 4R, we discuss this every class. So 4R is reading material, review, refer, red flags. Okay. So because this patient is now admitted in the hospital, you don't need to talk about review. You are not going to refer the patient because he's in hospital. You don't need to even give the red flags because he's admitted. This will be done when you want to discharge the patient. Right now, we are only using the reading materials. Now come to the most important one, MI. A 55-year-old man comes to your emergency department with sudden onset crushing chest pain. Take history, physical examination, ask investigation from examiner and explain the likely cause of his chest pain and immediate management. Now, this is one case, and then there is another case which is not added in this note, but there is another case which we normally do it in the cardiology role play session, that you are in a rural hospital and a patient who is 55 coming to you with a sudden onset crushing chest pain. And the tertiary hospital is 3 or 4 hours away. The ECG will be given on the stem. So you'll be able to see in the first 2-minute time that the ECG is a ST elevated MI patient. They will ask you to take a short history, and then sometimes they can say explain the investigation to the examiner, but mostly they will ask you about the diagnosis and further management. Okay, so 2 different cases. Now, as I said, that if you don't know the ECG at first, then we will follow the same thing. Same way how we have done the first chest pain case. So you start with the introduction, reassurance, make sure patient is vitally stable, offer the painkiller, and then go on with the history. Okay? That's the way to go if the ECG is not given. But if the second case, when the ECG is given and you know that it is a ST elevated MI patient, that has a different approach to start. So what we will do in this case is that when you first you introduce with the patient, reassure the patient that you are going to take care of him. And then you will excuse from the patient and go to the examiner and ask for vitals. So examiner in this case, they can say, yes, go on, proceed. But what you would need to say to the examiner at that time is that you want to start the immediate management for this patient because you don't want to waste time. So you will say that, dear examiner, as my patient's ECG is concerning, along with the history, I would like to take my patient to the resuscitation cubicle, attach him on cardiac monitor, ask a nurse to do a ECG, will secure an IV line, take blood for investigation, especially cardiac enzyme, start the patient with oxygen morphine, and a loading dose of 300 milligram aspirin, unless patient has any contraindication to it. What you have done is that it's called monotherapy. Monotherapy is the initial treatment for any patient who has this possible MI. So morphine, you have offered it already. Oxygen, nitroglycerin, aspirin. Nitroglycerin is not must to say yet. You can do it later on. But aspirin, morphine, oxygen, you will say it in here. Okay? So even though if the patient is still vitally stable, this patient has likely ST elevated AMI. So you will take this patient to the resuscitation cubicle, attach him on cardiac monitor, and do an ECG, secure IV line, do the cardiac enzyme, start the patient with morphine, 300 milligram aspirin, unless there is any contraindication, and an oxygen. Then thank the examiner, come back to the patient, and then you will start the questions. So you'll offer the painkiller, and then you start with the chest pain questions and everything. Now, that case where you have the ECG of ST elevation, your task will be take history for 2 minutes or 3 minutes. So it will be a very short history. In that case, ruling out a lot of differential diagnosis will not be necessary. So your main part will be asking the chest pain questions, asking the other associated questions, and then ruling out some of the important DDs, like especially some of the other heart-related DD. No need to ask any other DD like respiratory, the psychological, GIT, any of them. And then just ask the risk factor like SADMA, smoking, alcohol, ask about past history of heart condition, any associated high blood pressure, diabetes, because this is just all the risk factor for cardiovascular disease. So you'll just ask those. So there is a different approach for that case, okay? So once you have done that, they will give, so the second case, you already have the ECG, but the first case, you will get an ECG from the patient, from the examiner after taking the history. So, and you might need to even explain the ECG to the examiner. So how the ECG can look like. So let's have a look for a ST elevated MI, right? So this patient has got a chest pain. So we can see that V1, everything looks okay. How about the V2? So this is the isoelectric line. And we can see that ST is elevated. V3, you can see ST elevation. V4 ST elevation, V5, V6 ST elevation. Then we look at lead 1 and AVL. Lead 1 has ST elevation. Lead AVL has ST elevation. So it's kind of an extensive anterior AMI. Then we look at the inferior lead. So we can see lead 2 is normal. Lead 3 has got maybe a bit of ST depression, but okay. AVF also normal. So that means that fulfills the reciprocal part, right? So we know that if it is anterior MI, inferior lead, usually ST should be fine. So either ST will be normal or depressed, not elevated. So this will be a case of anterolateral MI. How about this one? Can you guys find out where the ST elevation is? Okay, so if we see the V1 ST elevation, V2, V3, V4, V5, P6 not much. So they all have an like a AMI, like a ST elevation, lead one, lead AVL. So this is also anterolateral, right? And lead 2, 3 AVF is mostly okay. So that is anterolateral AMI as well. So once you have, so you'll need to explain this ECG to the examiner. So the same way, so you'll say the rate rhythm, P wave will be normal, QRS will be normal. The only problem will be ST elevation. So you'll just need to explain that there is ST elevation from V1 to V5, including lead 1 and AVL, and normal ST in 2, 3, and AVF. So that is the only thing that's abnormal in this patient. So then you come to the management. So thank you so much, John, for waiting. John, based on the nature of your chest pain and also the ECG that we have done, I'm so sorry to inform that most likely you are having a heart attack or acute myocardial infarction. I'm really sorry, John, but it is a serious condition. John, do you have any idea that what is heart attack? No, doctor. Well, in this condition, the heart is supplied by some coronary arteries, which supplies your heart. There are some vessels that goes to your right side and left side of the heart. In this condition, some of the blood pipes that supplies your heart can get fully blocked. And as a result of that, the part of the heart that was getting supply from that blood vessel, that heart, that heart muscle no longer get any oxygen or blood, and it can get like irreversibly damaged. And that can cause serious complication. And sometimes this kind of condition can be even life-threatening. John, I'm so sorry to say all of this, but I want you to know that you are in safe hand and you have done very good to come here as soon as possible. And with immediate intervention, this kind of condition can be managed very effectively because we have got a very good team of cardiologists in the hospital. But right now, we don't have much time. We need to admit you to the hospital. I'm going to call my senior who will also come and see you, and a cardiologist will come for further management. In the meantime, I have already, so let's say this is the first case. In the meantime, I'm going to transfer you to the resuscitation cubicle for urgent management. I will hook you in a monitor to have a constant check of your ECG. We will also take some necessary blood for investigation, including your cardiac enzyme to confirm the heart attack. In the meantime, we will also make sure to give you painkiller if you have still some chest pain. We will give you a high dose aspirin, which will help to reduce any further clot formation. If your oxygen goes low, we will also start you with oxygen by mask. Even after morphine, if you still have ongoing chest pain, we will give you another medication under your tongue known as nitroglycerin. Are you with me so far, John? Are you understanding me? Yes, doctor. Now, when the specialist will come and discuss about the further management. The most definitive treatment for this condition is to take you to the catheter lab urgently, where they are going to remove the clot and restore the blood flow, which is also known as percutaneous coronary intervention. In this intervention, they take you to the theater, they put you under sleep, and then a small flexible tube will be passed from your arm or groin, and then it will go into your heart arteries to find out where exactly is the block. And it will take the clot out and put a stent there which will keep the blocked artery open, and that will make sure the blood supply is restored into that part of the heart. I know it sounds very scary and complicated, but please trust us that like there are lots of patients who present in this way, and that our team has absolute experience to treat something like that. If you want me to call your partner, friends, or family members, please ask me. I will be more than happy to contact them. John, do you have any questions at the moment? So remember one thing, that the case in here is mainly asking about immediate management. So immediate management finish here. So as long as you talk about the percutaneous coronary intervention or thrombolysis, that's where the immediate management is done. You don't need to talk about what will happen after the discharge. If the task is talk about immediate and long-term management, then you would add this, that once you are better and stable, the specialist will put you on further medication like this, and also your GP will see you and you'll need to adapt a healthy lifestyle. So these are not needed at the moment, okay? At the moment, you will finish that, yes, this is what will happen, and reassure the patient multiple times that we are going to take care of you. You have done brilliant job by coming here. But still, if you have any questions, feel free to ask me, or even you can ask it to the specialist. If you want me to call your friends, family member, your partner, please let me know. Okay? So that's the MI case. Now, this is the first case, right? The second case, where you have already started all the management, that is a bit different. So you'll say the same thing like this, and you'll say that I have already taken you to the resuscitation room. I have also started you with a strong painkiller, and also we are giving you a aspirin, which is to prevent any clot formation. And then, so you'll talk about this, and then you'll say that that patient is in a rural hospital. You can't talk about PCI to that patient. So you'll say the definitive treatment for this condition is to take you to a catheter lab and then remove the clot, put a stent in, and restore the blood flow. But unfortunately, this is a rural hospital and we don't have this intervention in this hospital. And the nearest hospital where this is available is 3 hours away. And it is not ideal to do that. So the next best option in this case is to start a thrombolytic medication, which is medication to dissolve the clot. It has side effects and contraindications. So I will make sure that you fulfill the criteria. I will also talk to the cardiologist over phone to make sure they are happy to proceed with this treatment. Once you are stable, we will send you to the tertiary hospital for further management. So that is the case where you are in a rural hospital. Okay? Does it make sense to everyone? Like, do you guys understand what I'm talking about? Do we need to explain detail of ECG to examiner? Yes, you need to. So if the task is to explain the ECG to examiner, then only you do it. No questions? You guys are enjoying the class? Is it very difficult? Okay. Moving on. So there is, if you open your notes in the portal, you will see that there is angina. Now, this doesn't come in exam a lot anymore. So I want you to just give it a read. We don't discuss that in the class anymore anyway, but we just keep it in case sometimes it just pop up in the exam. So give it a read in your own time. Same this one, angina due to anemia, doesn't come anymore. So worth just reading it, but we don't discuss. Okay. But serious risk assessment comes in exam, so definitely we are going to discuss that. Yes, Dr. Rebecca, you should be, because that's how the exam is going to be. So it is difficult to finish everything in 8 minutes, but you don't need to finish everything. You need to finish the important things. Okay? So if you want to finish everything, you will run out of time. The idea is to make sure that depending on how many tasks you have, you need to know how to cut short history. You need to know how to manage the time. And this only happens when you do a lot of role play. This is a clinical class, Dr. Patel. Are you MCQ student? So this class tonight is for AMC clinical, not for MCQ. Okay. So serious risk assessment. You're a GP. A middle-aged man comes to have a consultation after his brother went for coronary bypass 2 weeks ago. He is obese, no other past medical history. Task focused history, physical examination finding from examiner, explain what will be the initial management. So if you see here, GP, so GP setting, middle-aged man coming to you to have a consultation after his brother had a coronary bypass. So he is obese. You need to take a history and examination and then initial management. So these cases are about serious risk assessment and then doing some further investigations to, to prevent serious risk in this patient. So serious risk assessment comes in exam. And now that it is a face-to-face exam again, they might give you this chart also. So we will need to discuss that chart with you today. So how to take a history for serious risk assessment. We follow this mnemonic called ABCDEFS. But before that, you'll go in and you'll greet with the patient and you will say, I'm so sorry. So very nice to meet you, David. I understand that you are here to talk about something because your brother had a bypass surgery. How is he doing now? Is he okay? See that even though it is not really important for us to talk about his brother, but these are important. In exam, you are getting assessed for this because your patient just saying that my partner passed away. And if your response is, let's say, how is your mood these days? It means that you did not even bother about that. So you need to say something when someone say something sad or some bad thing happens to them. So you should definitely say, I'm so sorry to hear that. How are you doing? Same thing like this, that I'm so sorry to hear about your brother. How is he doing now? So that makes a lot of difference when an examiner is listening to you. Okay. So after that, you will say, so patient will say, yes, I'm just really scared that I don't want to end up like my brother. So I want to know how I can prevent this. So you will say, it's really good. I really appreciate that you are here to discuss that. So let me ask you a few questions and then we can make a proper assessment and go from there. How that sounds. So patient will say, that's really good. So then you go to the ABCDAFS question. So A for alcohol, B for blood pressure, body weight, C for cholesterol, D for diabetes and diet, E for exercise, F for any family history of heart condition, S for smoking, another S for stress. So we don't start with alcohol in a question. So your first question should be at the moment, do you have any chest pain? Do you get short of breath with any exertional activities? Any racing of your heart? So palpitation? Any blurring of vision? So find out if there is any retinopathy happening. So that means you can think that this patient might have some peripheral vascular disease or atherosclerotic problem. So any blurring of vision, any pain in your leg when you walk, that's for PVD. So these are just some idea that whether the patient already has some atherosclerosis. Okay. And most of the patient will say in the exam, no. Then you will say, so do you smoke or drink alcohol? So then you can start. How's your diet? Do you take healthy, balanced diet? How about exercise? How's your body weight? Do you know your BMI? Do you have any history of high blood pressure? How about any high cholesterol? Any history of diabetes? Any family history of heart attack apart from your brother? How is home? Is there any stress there? Any stress at your work? Any financial issues? Any other past medical or surgical history? So that should be your history in this patient. Very short history, but it should be focused history. After that, you thank the patient and go for physical exam. So physical examination will start with general appearance. So you would ask from the examiner, any sign of high cholesterol, such as xanthal asthma, xanthoma, any corneal arcus, any pallor icterus, any edema or dehydration. Ask about the vitals, where you can find out the blood pressure of the patient, BMI, and then do a quick, like a detailed cardiovascular exam, which will be your inspection, palpation, auscultation. Do a quick respiratory exam. So is there bilateral equal air entry, any added sound like any basal crepitation? Abdominal exam is not must in this patient. Office test, urine dipstick, blood sugar, and ECG. In here, at the end of the examination, ask from the examiner whether a cardiovascular risk assessment chart is available, because sometimes they can provide you that. So after your physical examination from examiner, just say, dear examiner, I would like to know whether the cardiovascular risk assessment chart is available. If not, that's fine. So explain to the patient. So it depends. So you should write in a paper in front of you that what are the risk factor you have got in this patient. So from the history and examination, I have found some risk factor, like you have high blood pressure, your body weight is higher than normal, you have diabetes, your diet contains fatty food rather than healthy balanced food, and you have been smoking for 20 years. All of this can put you on a significant risk of having some heart-related complication like your brother. But please don't get scared, because now that you are here, we can actually prevent this by adopting a healthy lifestyle. So I want you to start cutting down your alcohol to safe level, which is not more than 4 standard drink in a day. Try to maintain ideal body weight, avoid smoking fully, take some healthy balanced diet, do exercise, at least 30 minutes brisk walking, at least 5 days a week, and try to avoid stressful works. If you want to get some help about stopping smoking or alcohol, I would like to offer another appointment so that we can discuss further about it. And there are lots of ways that we can help you to cut down the alcohol and quit smoking fully. Also, I would like to do some blood test to get some idea that how's your cholesterol, blood sugar, and everything. So we'll do full blood count, kidney function. We'll do an ECG on your heart, blood sugar level, lipid profile, and thyroid function. I will review you. So this is the 4R. So I will review you after these blood tests are back. At the moment, I don't need to refer you to anyone. Once we get the blood test, then I will arrange a healthy heart check for you. Under this healthy heart check, we can assess all the risk factor, and we will put all of your risk factor, your age, sex, height, weight, your cholesterol, blood pressure in a 5-yearly cardiovascular risk assessment chart. And that chart will be able to give us how much risk you have to have a heart condition in the next 5 years. Based on that, further management, if needed, I will talk to you further if you have a high risk of heart condition. Otherwise, at the moment, I will give you reading materials about everything I have discussed, and I'm going to see you once the blood tests are back. Do you have any questions? So nowadays, this is a new thing that GP can do a healthy heart check. And with the healthy heart check, like this is eligible, anyone is eligible, especially if they have this kind of risk factor. And the GP can do a baseline ECG, can find out how much cardiovascular risk the patient has, and they can actually put all the information in this chart, and it will give us the risk. If it is low risk, then only management will be lifestyle modification. If it is a high risk patient, then you will actively manage any kind of secondary risk factor. Like if a patient is hypertensive, you will start medication for that patient. So only if the patient is high risk. If a patient has high cholesterol, you will start a statin for that patient. Okay, if the cholesterol is very high, like 6 or 7, you might even want to do a test called CT calcium score. And the calcium score can give us an idea how much buildup of cholesterol in the coronary artery. So a lot of things can be done based on this cardiovascular risk assessment. You don't need to know that much detail, but if you just mention that once the tests are back, we will bring you back for a healthy heart check where we are going to put your all the information in a chart, and it will give us a absolute risk. And then we will talk further about management. Okay? Questions? At the moment, Dr. Bora, it's also difficult for us to know when the exam date will be open because they don't have any particular timeline. They always change. So you need to just keep an eye in the amc.org.au website that when they're going to open it. So the November exam, it's not going to open before June or July. So I think up to June is all done, and then the next exam might be like July, August, September. They can even include October, November in that same timeline. So it just totally depends on them. Now I was talking about that healthy, like that this chart, right? So sometimes, especially because it is face to face, they can provide you the chart and they can ask you to estimate the cardiovascular risk for this patient. So to do this cardiovascular risk, we need to know a few things. We need to know what is the age of the patient? Is it a man or is it a male or female? We need to know smoking or not. We need to know the systolic blood pressure, and we need to know the cholesterol HDL ratio. So these are the important information we need. You can say that, so this one is people without diabetes. This side is for men and this side for women, and that's a smoker, non-smoker. So we know that this is men smoker. It's a 57-year-old. So that's the age group. And then at the y-axis, we have got systolic blood pressure, And in x-axis, we have got cholesterol HDL ratio. So right now, we are going to just focus on this part, right? Now have a look on the blood pressure. So 120, 140, 160, 179. Now don't think that this box that you see here, the highest limit is 120. It is not like that. The highest limit of this box is 130. Highest limit of this second box is 150. So if the blood pressure is 125, it will fall in here. Okay? If blood pressure is 135, that will come here. Right? So up to 130 will be in this box, up to 150, 70. So like that. So just add 10. Our patient's blood pressure is, systolic blood pressure is 160. So 160, we can see that it is the third box. So we know that we're looking at this box, right? Or third row. Then we look at this cholesterol HDL ratio. Cholesterol HDL is 8/1. So if you look over here, we're not looking at this, we're looking at this one. So 4, 5, 6, 7, 8. In the same way, 4 is not the highest number you will think of this column. It is 4.5. So up to 4.5 is in this column. Then in here up to 5.5, 6.5, 7.5. Now our patient has got cholesterol 8. So this is in here. So now we go up. So where it is. So this is where it is, right? So the red box. So once we get the red box, we just need to come down to this. So we can see the red box means high risk, more than 30% risk of having a heart condition in the next 5 years. So that's what they will ask you to find out and explain to the patient. Does it make sense? For everyone, it is clear. Let's say that if it is marginal, someone's blood pressure is 130. So we know up to 130 is here. If it is a marginal thing, then you go to the next box. So if it was 130, we will go to this box. So if it is marginal, which sometimes examination do, in exam they give you the marginal one and then you become confused. If it is marginal, go to the next box. Same in here as well. If a patient's cholesterol is 6.5, then you go to this second box or the next box. Okay. So if you know how to do this chart, it becomes very easy. Then you need to just explain to the patient how did you do it. So make it easy for the patient, and you will have a lot of time to do this. So just explain that this is a chart where we have all the risk factor for the patients in related to heart. We can put it here and find out their risk, whether they are low risk, moderate risk, or high risk. You can see that this particular chart has on the right side men and women, on the left side. Then there is a box for a smoker, and then there is another one non-smoker. And it is also divided by age. In your case, because you are male, you have a smoking history, and your age is 57, we are mainly focusing on this group. So you can actually now show, because they will give it to you. Then you will say, after that, we look at your top blood pressure and your cholesterol. First, we look at your blood pressure. Your blood pressure is 160. So we can see that 160 is in this box. Can you appreciate it? Yes. And then we check your cholesterol, which is 8. So when we check your cholesterol and the blood pressure as well, your number falls in this red box. Now, if you look at the red box, it has more than 30% risk of having a heart condition in the next 5 years. And that puts you in a very high risk of a cardiovascular event. And then you talk about further management. Okay? So you might think that it is very difficult to explain these things, but once you get the art of explanation and art of simplification, it is not really difficult. So it is in your own way, make a non-medical jargon explanation. So that's how you should actually try to do it. So there is no specific way of doing it. As long as patient understand you, you're good. All right, everyone, any questions? So there is a case of hypertension, which we will do that in the cardiology cardiology role play as well. Okay. Or sometimes what happens, because lots of cages are there, if few cages are still left, we will also do some role play on that. Okay. So in role play sessions, which is coming up, we will do some role play on mostly this theory class that we have done and some new cages as well. So try to finish all of this and come for role play. Okay. So how was the random role play session? Was it scary? Yep, that's very good. So random role play sessions are important, and it gives you a lot of idea. Lots of our ex-student come and do the role play in this class, and they are like almost prepared. So you get to see how they're doing the role play, and you can also learn from them as well. So it is a very interactive session. So your next class is on 26th, and that will be the role play sessions on cardiology. Dr. Bonnet, just send us an email or even send a message to me that you have been waiting for the account. At the moment, it is a bit tricky for our admin as well, because there is a lot of queries and questions. So it is taking a bit of longer time to give the access, but definitely we will make sure that all of you get access as soon as possible. All right, so that's it for tonight. Do you guys have any questions about the course? Because we're actually almost at the half of our free 2 week session. You only have 3 more class with us. So if you're still waiting to join the session, I would definitely advise, please don't waste any more time. Go ahead, start the process of enrollment, because it will be really important, because it takes some time. Sometimes, like, we ask you to create an account, and somehow, like, how you some candidate does not know how to create an account in the portal, so it takes some times. So I would advise you make sure to start the enrollment by this week, so that you have enough time to start the classes with us. And Dr. Vishnu also send me a message, because it will be important, we can check in our end as well. Okay. All right. We'll finish it here tonight then. Thank you, everyone. Have a good night. Take care.